Okay, let's go through this question on pediatric endocrinology, right? Let's read the question. Baby boy born at term presented on day 6 with poor breastfeeding and loss of weight. Thyroid screening test results TSH 50. What is the next step? Next step of management, right? So they have given 5 answers. So after reading this, so you can get a basic idea of the question. So it says a boy born at term on day 6 presents with these symptoms with thyroid screening test. What is this thyroid screening test? It is the capillary TSH test or the heel prick test, right? Results of TSH 50. TSH 50 is bit high. So with the given findings, you may understand that this is a baby boy born with congenital hypothyroidism, right? They're asking for the next step of management. So before answering this question, let's understand a bit about congenital hypothyroidism, right? Uh, what is meant by congenital hypothyroidism? Congenital hypothyroidism is the deficiency of thyroxine hormone, which is present from birth, right? It can be due to multiple reasons, but the commonest reason is thyroid gland dysgenesis and dysgenesis. So, in 85% of the time, congenital hypothyroidism is due to the thyroid gland not forming properly, right? And also, it can also be due to dyshomogenesis. So, 15% of the time, it can be due to dyshomogenesis. What is meant by dyshomogenesis? It means the enzymes required for the formation of thyroid hormone is not there in these babies, right? And also, rarely, it can be due to TSH deficiency. So, as you all know, TSH hormone stimulates the thyroxine gland to produce thyroxine, right? So, if this TSH hormone is not there, it can lead to congenital hypothyroidism, right? And these are the three commonest reasons for congenital hypothyroidism, right? And usually, how do these babies present? They can present with many clinical features, right? So they may be having non-specific features like excessive sleep and also dry skin, and they may have poor feeding, and also rarely there can be umbilical hernias. Likewise, there are many clinical features to identify congenital hypothyroidism, right? So as I mentioned before, uh, the screening test for congenital hypothyroidism is the heel prick test. Heel prick test, right? So it is done after birth of any baby, and it is a universal screening tool. And before the child is discharged from the hospital, they usually perform a heel prick test, the capillary TSH test, right? So when the child is having congenital hypothyroidism, his thyroxine levels are low, so due to negative feedback effect, the TSH levels becomes increased, right? So if the capillary TSH levels are high, we can suspect of congenital hypothyroidism, right? So in this question, this baby's TSH level is 50, which is bit high, right? Usually the normal capillary TSH level should be less than 20. Uh, and what is the next step of this management? Admit to the ward for further evaluation. Start thyroxine. Arrange ultrasound scan of the neck. Repeat TSH and T4. Reassure the mother and the child. Right? To answer this type of question, it's better if you go by a certain algorithm, right? So I teach you guys through a flow chart how to answer a question related to the management of congenital hypothyroidism, right? So as I mentioned, initially we perform a capillary TSH test, right? And if the TSH level is more than 40 milli-international unit per liter, it means the child is highly likely to have congenital hypothyroidism, right? Therefore, we start the child on thyroxine. As I mentioned, this capillary TSH is just a screening test, right? So we need a confirmatory test. Therefore, we order a venous T4 and TSH. And until the results of these venous T4 and TSH are available, we continue the child on thyroxine, right? And also, if the capillary TSH level is between 20 to 40 milli-international per liter, then what do? We don't start the child on thyroxine immediately. Instead, we request for a venous T4 and TSH. And the third instance, when the capillary TSH level is less than 20. There, the child is highly unlikely to have congenital hypothyroidism. There, we can reassure the mother that the child is not having hypothyroidism, right? So now, in both these instances, we have performed a venous T4 and TSH, right? Now what? Now what happens? Imagine the results of this test are available now, right? And you have the venous T4 results. And if this venous T4 result is low, the child's thyroxine T4 levels are low, again below the normal cutoff, we can, if we have already started thyroxine, we can continue. And if we have not started, the child was in this range, we can start thyroxine. So start or continue thyroxine, right? Okay. And if the venous T4 is normal and the venous TSH, this is venous TSH, right? Not capillary TSH. It's more than 20, right? In this instance also, we can start the child on thyroxine, even if the T4 levels are normal, right? Start thyroxine. Start or continue thyroxine. Okay. Now imagine the venous TSH level is between 6 to 20. All these sign milli-international unit per liter, right? The venous TSH level is 6 to 20. So the normal venous TSH level is 6, and this time it is between 6 to 20. In this instance, what we do is we repeat the test results, the T4 and the venous TSH in 2 weeks, and then we perform an ultrasound scan, right? Ultrasound scan, right? So we repeat thyroid blood test results in 2 weeks, and we do a ultrasound scan, right? Now you have the ultrasound scan results. So if the ultrasound scan shows a small or an ectopic thyroid, what we do is we start the child on treatment. If the ultrasound scan result is normal, then what do we do? So in this instance, what we do is we repeat thyroid function tests, which includes T4 and TSH levels until the venous TSH normalizes. In other words, it becomes less than 6. Okay. So through this flow chart, you can easily understand how we manage a child with congenital hypothyroidism, right? So in this question, the child has clinical features of congenital hypothyroidism, and also the thyroid screening test result is 50, right? So let's go to this flow chart again. So his TSH, capillary TSH level is 50. It means it's more than 40. What do? We start the child on thyroxine and we send blood for venous T4 and TSH, right? What is the answer here? Admit to the ward for further evaluation, no. Start thyroxine, yes. Arrange ultrasound scan of the neck, no. We arrange ultrasound scan only if the venous TSH level is between 6 to 20, right? No. Repeat TSH and T4. So repeat. We have not done it initially. Hence, this answer is irrelevant. Reassure the mother and child. We can't reassure here, right? So child is highly likely to have congenital hypothyroidism, right? And we need to start the child on thyroxine. And the answer is B, right? And how do we treat these children with congenital hypothyroidism? Ideally, the child, if we diagnose congenital hypothyroidism, the child should be started on thyroxine, ideally within the first 2 weeks, right? Because unless if we delay starting thyroxine, it can affect the neurodevelopment of the baby. Therefore, in ideal management, we should start the child on thyroxine. And the child needs thyroxine lifelong, right? And another practical thing they usually ask in the exams is how do we give thyroxine, right? Or do we give levothyroxine, the dose of 10 to 15 micrograms per kg, and we give these tablets dissolved in breast milk or water, and ideally they should be given empty stomach in the morning before the first breastfeed, right?